And you're going to see that a lot of what we've already talked about in the fluid and electrolyte section is applicable here, okay? Now, burns. The risk of death increases in the very old and the very young. The very old and the very young. Now, let me talk about that for a second. You know, when you're older, you don't have as much sub-Q fat. So, therefore, the burn can go deeper, can it? But when you're talking about a child or someone very young, you're talking about body surface area. You know, when you're listening to the news and somebody's been badly burned, they always tell you how much of the body surface area that's affected. The greater the surface area affected, the greater the chance of death, which we're going to talk more about that. But let's pretend we have an adult who was burned their entire left arm and a baby that's burned their entire left arm. Which burn covered more body surface area? The baby, okay? And the greater the surface area affected, the greater the chance of death. Now, where do most burns occur? At home. At home. So we have to think about safety things here. Covering electrical sockets, making sure the hot water heater's not set too high, things like turning pot handles inwardly on the stove, not putting hot things on a table with a tablecloth because a toddler could pull on it. Safety considerations, okay? Now, after a burn, many different pathophysiological changes occur, and of course, I want to know why, because we've already said why is the key to critical thinking and application questions, and that's what A through G are going to tell us. Now, A, why does plasma seep out into the tissue? I bet your teacher said increased capillary permeability. Capillary permeability. Now, what does permeable mean? It means it's leaking. The heat has damaged the vessel, so leakage is occurring out of the vascular space. Out of the vascular space into the tissue. That's why burn people get so swollen and edematous, because their fluid is leaking out. But also, as that fluid leaks out, what is happening to the vascular volume? It's going down, really getting shocky. Now, when does the majority of this occur? I'm talking about the leaking out now. First 24 hours. The first 24 hours. That's why during the first 24 hours, the patient can become almost unrecognizable. Because one minute you look at them, and then they're just look like they're been badly burned. Then you come back 8 hours later, and all their fluid is gone out. They're just swollen terribly. Now, why does the pulse increase? Because anytime you're in a fluid volume deficit, pulse increases, right? What's your heart trying to do? Compensate and pump what little you have left around. Why does the cardiac output decrease? Because there's less volume to pump, or fluid. Less fluid to pump out. Less volume to pump out. Why does the urine output decrease? Because the kidneys are either trying to hold on or they aren't being perfused. Now, why is epinephrine secreted? Well, it's going to make you vasoconstrict to shunt blood to vital organs. Hey, now when you first become burned and you come in contact with all of this heat, you're going to vasodilate, which makes your pressure drop. That's why we were built to have these stress hormones like epi and norepi, because it makes you vasoconstrict, we said. Now, why are ADH and aldosterone secreted? See if you and your friend can fill in those blanks. Retain sodium in water with aldosterone and retain water with ADH. Water with ADH. Now, y'all, the purpose of all of that is to replenish blood volume, isn't it? Yeah, rebuild your blood volume again, because we've lost so much of it. Where have we lost our blood volume? Out into the tissue or out of my body altogether, right? All right. Therefore, your blood volume will go up. Now, what is the most common airway injury? It's called carbon monoxide poisoning. Carbon monoxide poisoning. And here's how it works. Normally, oxygen should bind with hemoglobin. That's what's supposed to happen. Carbon monoxide can run much faster than oxygen, therefore it gets to the hemoglobin first and binds. Well, can oxygen bind now? No, there's no room for it. So basically, with carbon monoxide poisoning, what's happening is this. You've got two things in a race, oxygen and carbon monoxide. All right? Who's faster? We've already said carbon monoxide, but you put oxygen on this person, okay? Like 100% O2. You put 100% O2 on them, and you're putting 100 more oxygens in the race than carbon monoxide, right? Yeah, increasing the probability that who's going to get there first? An oxygen, simply because there's just more of them, you see. So here's a time when it's perfectly acceptable to put on 100% O2. That's the treatment. Now it says on your handout that carbon monoxide poisoning cannot be determined with O2 sats. The sat monitor picks up anything that is bound to hemoglobin, so if carbon monoxide is bound to hemoglobin, then the sat may appear normal. Okay? Another test they may do is a carboxyhemoglobin, which is a blood test to determine carbon monoxide poisoning. Okay? Well, now the patient is hypoxic, and the treatment's 100% O2. All right, on the next page. From this information, do you think it would be important to determine if the burn occurred in an open or closed space? Yes. When you see, because y'all think about it, if you were burned in a closed space, you will have inhaled more what? Carbon monoxide. Carbon monoxide. When you see a patient with burns to the neck, face, chest, you had better think what? Airway. And what might the doctor go ahead and do prophylactically? I heard two answers. I heard intubate and trach. Now what's the answer? Both are correct answers. Here's the test taking strategy. Least invasive first. Least invasive first. If you were the patient, wouldn't you prefer that they try the tube before they get out the scalpel? Yes. So intubate first, then trach would be a second option. Both answers are correct, y'all. But you've got to go for the least invasive first. You know, there's a chance when they start trying to put down that ET tube that it won't go down because so much swelling has occurred. Then they're going to have to trach the patient. Okay? A patient is burned over 40% of their body. How do you think this is determined? It's called the rule of nines. The rule of nines. Rule of nines, which is an estimate of the total body surface area burned. An estimate, right? So here's where you get to memorize some numbers, okay? Now, the head counts how much? 9 each arm, 9 each leg, 18 anterior trunk, 18 posterior trunk, 18, and the only one people always remember consistently across the United States, genitalia, 1 point. I'm sorry, it's 1 point, okay? Now, one of the most important aspects of burn management is fluid replacement. Fluid replacement. It is not uncommon for albumin to be given after a major burn. It's just not given in the first 24 hours. Think about it. If you give albumin in the first 24 hours, is it going to leak out? Yeah, because we still have vessel damage at this point. So it just leaks out. So they're really focusing on just fluids, fluids, fluids. And even those fluids that you're putting into the vascular space just leak out. But that's why the patient really gets edematous. But you got to do something to maintain some volume in there, to maintain a pressure. Okay? You know that albumin holds on to what in the vascular space? Fluid in the vascular space. This will increase or decrease the vascular volume. Increase the vascular volume. What will it do to kidney perfusion? Increase. What will it do to blood pressure? Increase. What will it do to cardiac output? Increase. Will this help correct the fluid volume deficit? Yes, because, y'all, with all of those things, we're putting more fluid where? In the vascular space. When you start giving a patient albumin, you know that the vascular volume will increase. What will happen to the workload of the heart? Increase, because there's more to pump. And that's okay to a certain point. However, if you stress the heart too much, you know that the patient could be thrown into fluid volume excess. And if this occurs, what will happen to cardiac output? Decrease, because now your heart is failing. It's wearing out. And so what will the lung sounds be like? Wet, crackles, whatever you want to say. On any patient who is receiving fluids rapidly, what is a measurement you can take hourly to make sure you're not overloading them? Ask the person sitting next to you. And notice the hint is heart. I know if it said heart, you didn't just say hourly outputs. That didn't even come into your mind, I know. CVP is the answer. CVP. Now here's the deal with the CVP. Anytime you're giving fluids fast, it's a wonderful thing to have a CVP. Because you can look at that right atrial pressure. That's the same thing as CVP, RAP, right atrial pressure. And if you see that number, that CVP number, go up too fast, all you've done is filled up the right atrium. When that number goes up too fast, all you've done is filled up the right atrium with fluid. And therefore, you're about to throw the patient into right-sided heart failure. That's that heart can't keep up with the volume that you're putting in, so it just starts building up and building up. Well, that's right-sided heart failure about to happen. So anytime you're giving fluids fast to somebody, if you have a central line, check that CVP often, because if it jumps up too fast, you're throwing them into right-sided heart failure. But a lot of people will think, well, the number's up, so we must have hydrated them. No, all you've done is filled up the right atrium and made the number go up. Is it important to know that the burn occurred at 11 p.m.? Yes. Why? Because you know that fluid therapy for the first 24 hours is based on the time the injury occurred, underline injury occurred, not when treatment was started. You've got to know the time the injury occurred because of the common rule at the top of the next page. Calculate what is needed for the first 24 hours and give half of it during the first 8 hours. They call that the Parkland formula, and I had that listed on your handout. Y'all, you're giving half of the total volume when? In the first 8 hours. So if you've got somebody who was burned at 12 o'clock and they don't make it to a hospital until 2 o'clock with no fluid replacement, we've already lost 2 hours of fluid replacement, haven't we? We only have 6 hours left to get half of that volume in, don't we? Okay, that's why the time that the injury occurred is most important. Now, to calculate fluid replacement properly, you also need to know the patient's weight and total body surface area affected. Now, the only reason I even have that on there is this. Different doctors will use different formulas for fluid replacement. Okay? And so different formulas want different numbers to plug into the formula. Now, if a patient is restless, it may mean fluid replacement is inadequate. It might mean pain, or it might mean hypoxia. It might mean all three of them. Out of those three answers, which one takes priority? Hypoxia, because that is the one that will kill you. Now you're catching on. Now, let's think about this for a second. If you've got somebody that's hypoxic. Well, first of all, let's go back to the first semester of nursing school. Y'all all remember Maslow's triangle, don't you? Yes. And your teacher told you that on the bottom of the triangle that Air, like air, food, and water, those are your lower level needs. But your teacher told you that lower level needs come first. Your air, food, and water. Airway, that's why you always pick airway for everything, right? Okay. On NCLEX, pain is a higher level need. And your teacher told you that higher level needs come later. Rule, pain never killed anybody. Pain won't kill you. Now, if you're the patient, pain's a pretty high priority for you. But when you think like NCLEX is about keeping people alive, and pain never killed anybody. Now, why is this important? Because what if you have a question on NCLEX where you're coming out a report and you've got 4 patients to go see, and it says, which patient will you go see first? They're always going to put somebody in pain because they know new nurses are like, pain, you got to deal with that. Before you pick the pain, you look for something more life-threatening, like somebody going into shock, ICP going up, blood sugar dropping. You see what I'm saying, y'all? Pain will not kill you. You think it's going to kill you, and yes, pain can be a sign of worse things to come. But if it says which patient takes priority, before you pick pain, you better look for something more life-threatening. Now, am I saying as nurses we ignore people in pain? No, I'm saying if you want to get the question right on NCLEX, you go see the life-threatening thing first and send somebody else to relieve the pain. You still deal with it, okay? All right. Now, if you had to pick, which of the following would you choose to determine if a patient's fluid volume was adequate? Their weight or urine output? Here we're going to pick urine output with Burns. Y'all, all other times, daily weights would be my favorite answer. Now, here's what I always say. 99% of the time, daily weights are an excellent indicator of fluid volume status. Did you hear what I said? I said 99% of the time, weight is an excellent indicator of fluid volume status. Just not right here. This is the exception to the rule. Now, why is this a different time? Because in the burn patient, are you really putting the fluid to them fast? Yes, you're putting fluid to them. So what are you doing to their weight? I'm making their weight go up. So that's why weight isn't as good an indicator as the urine output here. Our patients' respirations are shallow. You know they are retaining what? CO2. Therefore, which acid-base imbalance will they have? Respiratory acidosis. Our patient was given only 5 milligrams of morphine when the order was for a max of 10. Why did the nurse do this? Well, the nurse might have been worried about the respiratory rate, for one thing. But also your teacher told you that you only give the smallest amount necessary to relieve the pain, right? Yeah, the smallest amount of narcotic necessary to relieve the pain. That's a standard. And why are IV pain meds preferred over IM with burns? Because they act fast. They act fast. But also, you know that for an IM to even work, you've got to have a good muscle with good circulation. Do you have that with badly burned patients? No. Okay, so an IM's not going to do us much good anyway here. Now, why has the patient been given a tetanus toxoid plus the immune globulin? Well, let's talk about it. When you give somebody a tetanus shot, what is their body being forced to produce? Antibodies. But it takes about 2 to 4 weeks to get those antibodies in the bloodstream. But y'all, when you've been badly burned, do you need protection from tetanus today? Yeah, we don't need to make them wait 2 to 4 weeks. That's why we go ahead and give them the what? Immune globulin. Anytime you see the words immune globulin, think immediate protection. Because what are you directly giving to this patient? Antibodies. You're giving them the antibodies with immune globulin. Now, notice it says active and passive immunity. With the tetanus shot, your body is having to work to make the antibodies, isn't it? Yeah, you're having to work to make the antibodies. That's why we call it active immunity. With the immune globulin, your body didn't have to work because you gave the patient the antibodies. That's why we call it passive immunity. Do you think there's more death with upper or lower body burns? Upper because of my airway, respiratory system. Now, a patient has a circumferential burn on their arm. What does circumferential mean? Goes all the way around and cuts off my circulation. The second part of the question says, what should you be checking? Well, circulation, right? Now, tell your friend the 4 major checks you need to do when you're doing a circulatory check of an extremity. A circulatory check of an extremity. Ask your friend. Skin color, skin temperature, capillary refill, and the priority assessment is a pulse. Priority assessment is a pulse. Skin color, skin temperature, capillary refill, pulse. Now, if your friend said turgor, you tell your friend that turgor is a hydration check, okay? And if they said sensation, that's true. Sensation is a sign of a circulatory problem, but I just like to reserve that one, sensation, for when I'm doing a neurovascular check, like with orthopedic injuries, okay? All right, because that one can be nerve or it can be circulatory. So in this class, when I say do a circulatory check, that means skin color, skin temp, capillary refill, pulse, okay? Now, if a patient's vascular checks in the arm are bad, the doctor may do what procedure to relieve the pressure? Escharotomy. I'll spell it. Escharotomy. E-S-C-H-A-R-O-T-O-M-Y. Now, in a minute, we're going to talk about another type of escharotomy where they're removing dead tissue. Okay? The purpose of this escharotomy is to relieve the pressure, to restore the circulation. Relieve the pressure, restore the circulation. Now, I heard somebody say fasciotomy. Well, that's another way to relieve the pressures with a fasciotomy, but that is a deeper incision. You're cutting way deeper into the tissue, but that's still applicable here. Our patient was wrapped in a blanket to stop the burning process. Since the flames were gone, does that mean the burning process had stopped? No. What else could have been done to stop the burning process? Water. Ice water? No, just cool water. You never put ice on a burn. Never put ice on a burn because that causes too much vasoconstriction. Too much vasoconstriction. Well, how else did the blanket help? Well, it held in body heat and kept out the germs. Why is it important that jewelry be removed? Swelling, for one thing, okay, and then metal gets really hot, doesn't it? Okay. Now, what kinds of things do we look for to determine if any airway injury has occurred? Well, singed facial hair, dark sputum. And then if they've inhaled a lot of smoke, like they've been in a closed space, they'll have soot, the black stuff all over the face. Soot, S-O-O-T. So those are things that we look for. And when we see a lot of that, any of those things, you can anticipate that the doctor's going to want to go ahead and do what? Intubate, just to be on the safe side. Because what is that airway about to start doing? Swelling. A Foley was inserted so you could measure urine output. How often will this need to be monitored? Hourly. Is it possible that when you insert the catheter that no urine will return? Yes. Why? Because the kidneys are either attempting to conserve the fluid or they might not be being perfused adequately. You know, if you're not perfusing your kidneys adequately, you're not going to make urine. Okay? Now, what would you do if the urine was brown or red? Well, the first thing I want you to know is that is normal after a major burn. Normal after a major burn, but I'm still worried about it. It's normal after a major burn, but we are still worried about it. Now, let's talk about that for a second. Do you agree that with burns that there's a lot of cellular destruction? Yeah. When cells rupture, y'all, they release heme. That's the pigment. That's what's discoloring the urine. Okay, so the color of the urine is not a big deal, but you got to think about what that discolored urine means. You've got a lot of broken down cells in the body. There's only one way that broken down cells can escape from your body, and that is through the kidneys. So when I see that discolored urine, I know we've got broken down cells. Now here's the number one concern. Broken down cells can clog up your kidneys. Broken down cells can clog up your kidneys. And now I have to worry about renal failure, don't I? Yes, we have to worry about renal failure. So when we see that dark urine, we know we've got some kidneys that need flushing out, don't we? We've got to get those broken down cells out. Now, if there is no urine output, or if it is less than 20 cc's per hour, what would you start worrying about? Same thing. Renal failure. Renal failure. Now, what drugs might be ordered to increase kidney perfusion? Well, the doctor may order some Lasix. You see, we're trying to save the kidneys. The confusing part here is this. You know, in the first 24 hours, your vascular volume has gone out, right? And then here we are giving people Lasix. Well, you've got to keep the kidneys alive, too. So, yeah, it's going to make them diuresis and lose more volume, but you've got to perfuse the kidneys to keep them alive, to keep the kidneys alive. Another drug that may be used here is going to be dobutamine to increase cardiac output. Dobutamine to increase cardiac output. And you know that anytime you're increasing cardiac output, you're perfusing your kidneys more, aren't you? Yeah, perfusing your kidneys more. After 48 hours, the patient will begin to diurese. Why? Because fluid is going back into the vascular space. And now we have to worry about fluid volume excess. And what will naturally happen to the urine output during this time? It should increase. But y'all, is there a chance that my kidneys went without perfusion for so long that maybe they're not working properly? Yeah, but I hope the urine output goes up. Now, the patient's serum potassium level is 5.8. You know that potassium likes to live inside or outside of the cell? Inside of the cell. But with a burn, what happens to cells? They rupture, they lyse. So, what happens to the number of potassiums in the serum? Increased. You see, y'all, every time a cell ruptures, it releases potassium into your bloodstream. Therefore, you better monitor your patient for which electrolyte imbalance. Is it hypo or hyperkalemia? hyperkalemia. Now, why do you think Milana, Protonix, Pepcid, or Reglan are ordered? Stress ulcers can occur. Curling's ulcer. And I've listed for you some more examples of drugs in the little box there. Now, why do you think the doctor wants the patient to be NPO and have an NG tube hooked to suction? Paralytic ileus. They may have a paralytic ileus. Paralytic ileus. That's when the GI tract shuts down. No bowel sounds. And if a patient doesn't have bowel sounds, what will happen to the abdominal girth? Increase. On the next page, do you think the patient will need more or less calories than before? More. Now, what do they need a lot of in their diet to promote wound healing? Protein and vitamin C. Protein and vitamin C. And the NG tube will be removed when you can hear what? Vowel sounds. When you start GI feedings, what could you measure to ensure that the supplement was moving through the GI tract okay? Residuals, that's right, gastric residuals. Now, just a common order here is this. Hold feeding if residual greater than 50 or 100. It just depends on your doctor, okay? So what you do is you get you a big old syringe, right? And you aspirate stomach contents. And if more than 50 cc's comes out, what do you do with the tube feeding? Turn it off. Because is the patient moving stuff through the GI tract? No, and that can be dangerous, can it? Because if I'm not moving stuff through my GI tract and out of my stomach, it's going to build up and eventually I'm going to vomit and then aspirate, you see. Now think about this, y'all. Now I've got this big syringe full of stuff. What do I do with this stuff? You better give it back to the patient. The standard is to give it back to the patient because did we pull out fluid, electrolytes, and acid? Yeah, if you don't give it back to them, you can throw them into a fluid and electrolyte or an acid-base imbalance. So you got to give it back to them. It's their stuff, isn't it? Yeah, give them their stuff back. But y'all, every once in a while, you'll run across a doctor who'll say, discard the residual. That's not the standard, okay? For this test, we have got to learn the most commonly accepted thing across the United States. And then when you get out there in the real world, you adapt to your environment and your hospital and the doctors that you work with, okay? We're learning safe things for NCLEX here. What is some lab work you could check to ensure proper nutrition and a positive nitrogen balance? Total protein or albumin. Total protein or albumin. Total protein or albumin. Albumin is a type of protein. Anytime you want to know something about nutrition, think protein or albumin, y'all. Now, most of the time when people see the word nitrogen, they automatically think BUN. BUN is a kidney check, not a nutrition check. Now, since the patient has second and third degree burns, is it possible that they could have problems with contractures? Yes. And since they have burns on their hands, what are some specific measures that may be taken? Well, splints to prevent contractures. Splints. And your teacher told you to wrap each finger how? Individually, separated. If you don't wrap them separately, they'll grow together. Now, let's pretend your patient has a burn on the anterior portion of the neck, right here. As this burn starts to heal, naturally it's going to pull at the tissue, so what's it going to do to my chin? Pull it downward. You don't want that. So during the healing process, you hyperextend. Neck, head back. Hyperextend, no pillows. Now, if a patient has a perineal burn, what do you think the number one complication will be? Infection. Perineal infection. What is eschar? Dead tissue. Does it have to be removed? Yes. If it's not removed, can new tissue regenerate? No. And what likes to grow in eschar? Bacteria. What type of isolation will you use with this patient? Reverse or protective, it's the same thing. Reverse or protective, it's the same thing. Now let's think about that for a second. Normally when somebody's in isolation, it's because they've got something we don't want, right? Or it's something that we don't want to get throughout the hospital like TB. But this person is so immunosuppressed, we're protecting them from us. Travase, collagenase are enzymatic drugs that eat dead tissue. In other words, they debride, don't they? Yes. Don't use on face, don't use if pregnant, don't use over large nerves, don't use if area open to body cavity. So you're saying, well, where do you use it? You just have to be really careful, don't you, with it. These are very potent at eating away tissue. If you put them on the face, it's going to leave a scar. If you put it over a place that's open to a body cavity, it can eat away at the internal organs. So you just have to be very careful. Another way they debride is with hydrotherapy, also known as whirlpool. Now, before you send somebody for their whirlpool treatment, you better make sure you have medicated them, right? Give them pain medicine. It's very painful. On the next page, you'll see that I have some drugs in a little box there. You do not have to memorize all that. Just read over it sometime, be familiar with it, but don't try to memorize it. The most important thing is the next statement. Why should these drugs be alternated? In other words, why do we not use the same drug over and over and over again? The bacteria will build tolerance, resistance. The bacteria will build tolerance or resistance. They'll get used to it, in other words. It says broad-spectrum antibiotics are avoided to prevent super or secondary infections. However, they will be used until the wound cultures have returned. Now, what will a broad-spectrum kill? Everything. That's not good, because you don't want to kill the normal flora too, but while you're waiting for the cultures to come back, you got to give the patient something, because it takes about 72 hours to get cultures back. You can't let a burn patient go 72 hours without some form of antibiotic. Now, I want you to do something for me. I want you to tell the person next to you the most important thing to know about obtaining wound cultures and antibiotics. Antibiotics. Tell your friend, what's the most important thing to know about wound cultures and starting antibiotics? You never start the antibiotics until the cultures have been obtained, right? That's for any kind of culture. Major mistake when that happens. I saw that happen one time on a newborn baby where somebody started the antibiotic before the blood cultures there have been drawn on a meningitis baby. It's very serious. See, it messes up all your cultures, doesn't it? All right. Now, if grafting is done, a pressure dressing will be applied in surgery. See, y'all, where they remove the good skin from, it's going to bleed. So they put a pressure dressing on it, and then when it stops bleeding, they leave the area open to air. And if the patient is well nourished, I said well nourished, they can keep reharvesting from that same site, because you'll keep growing skin at that same spot. Now, if the skin graft should become blue or cool, what would this mean? Poor circulation. And sometimes the doctor will order for you to roll sterile Q-tips over the graft with steady, gentle pressure from the center of the graft out to the edges. Why? Well, if I've got a new graft up here, can fluid or blood or exudate accumulate underneath? Yeah, it can. Well, if it does, can my new graft adhere? No, so it's got to be, the doctor may aspirate it out, or you can take a Q-tip and roll the stuff out from underneath so it will stick. If a patient has a chemical burn, what do? Flush with water. Flush with water. However, if it were a powdered chemical, what should you do with the powdered chemical first? Brush it off. Now, if the patient has an electrical burn, there will usually be two wounds. What are they? Entrance and exit. Your teacher told you that when electricity goes in through the body, I bet they said this, it seeks the path of least resistance. In other words, it's trying to find a way to get out, isn't it? Yes. So the electricity comes in, and you have an entrance wound, but you also have an exit wound too, don't you? But could I have internal damage as well? Yeah, you can't forget about the internal damage. If a patient comes in with an electrical injury, what is the first thing you should do? Put them on a heart monitor for 24 hours. Because what arrhythmia is this patient at high risk for? VFib. And you know that when somebody goes into VFib, we need to know it fast, right? So we can hurry up and shock them, defibrillate them. I bet your teacher told you this. The longer you wait to defibrillate, the greater the chance it's not going to work, right? That first 24 hours after an electrical injury is like a danger time, all right? So we want to be sure and keep them in the hospital for 24 hours. If they can make it past that 24 hours without getting an arrhythmia, they probably aren't going to have one. With electrical burns, toxins can build up and cause kidney damage. Hey, y'all, kidneys are very vascular. And you're going to see that electricity loves to kill any kind of vascularity. It is not uncommon for this patient to be placed on a spine board with the C-collar because it says on your handout, electrical injuries tend to occur in high places. Because what I mean is maybe somebody's up on their house working on their little satellite dish and they're electrocuted, okay? I know that I've seen a case before where somebody was working on a billboard and the metal device they were using to help put up the billboard went up into the light socket and they fell down. So C-spine injuries are very common because electrical injuries tend to occur in high places. Now, are amputations common? Yes. Why? Because electricity kills vascularity. Electricity kills vascularity. That's why the kidneys are damaged. Because kidneys are so vascular. And other complications of electrical wounds, cataracts, gait problems, and just about any neuro deficit you can think of. Wherever you've got a vessel, you've got a nerve. That's why after you see somebody who's been struck by lightning or have a severe electrocution of some sort, their gait may never be normal again because of all the nerve damage that has occurred. All right, enough on burns.